You're listening to the Anesthesia Patient Safety Podcast, the official podcast of the Anesthesia Patient Safety Foundation. We're bringing you the very best from the APSF newsletter and website, as well as the latest information in perioperative patient safety. Thanks for joining us.
Hello, and welcome back to the Anesthesia Patient Safety Podcast. My name is Allie Bechtel, and I'm your host. Thank you for joining us for another show. We are so excited to continue our conversation of the excellent articles from the June 2025 APSF newsletter. But before we dive further into the episode today, we'd like to recognize Nihan Koden, a major corporate supporter of APSF. Nihan Koden has generously provided unrestricted support to further our vision that no one shall be harmed by anesthesia care. Thank you, Nihan Koden. We wouldn't be able to do all that we do without you. Our featured article today is Perioperative Stroke Prevention, a review of recent guidelines for non-cardiac and non-neurologic surgery by Robert Pranat and Jacob Nadler. To follow along with us, head over to apsf.org and click on the newsletter heading. The first one down is the current newsletter. Then scroll down until you get to our featured article today. I will include the link in the show notes as well. We have exclusive content from one of the authors to help kick off the show today. Here he is now.
Hi, my name is Jacob Nadler, and I'm Chief of the Neuroanesthesiology Division within the Department of Anesthesiology and Perioperative Medicine at the University of Rochester in Rochester, New York.
I asked Nadler why he is so passionate about this topic. Let's take a listen to what he had to say.
I'm passionate about brain health because neurologic complications impact our patients' identity and humanity in a way that other serious perioperative complications like infection or kidney injury might not. By maintaining brain health, we're preserving the essence of who our patients are, their memories, their personality, their ability to connect with their friends and family. To me, brain health is not just a medical concern, but a deeply personal and philosophical one. This area offers tangible opportunities to avoid what I see as really existential complications.
Thank you so much to Nadler for contributing to the show today and helping to highlight how important this topic is for anesthesia professionals. The stakes are quite high, and we need to remain vigilant to help keep our patients safe during anesthesia care. Now it's time to get into the article, and we'll get started with the definition. Perioperative stroke is a brain infarction of ischemic or hemorrhagic etiology that occurs during surgery or within 30 days postoperatively. The good news is that this is an uncommon event and may occur in between 0.1 and 0.7% of patients undergoing non-cardiac surgery, according to data from the American College of Surgeons National Surgical Quality Improvement Program. Further investigation into perioperative stroke has revealed the following. The greatest risk factors for postoperative stroke include history of stroke, including transient ischemic attack, advanced age, anemia with a hematocrit less than 27%, and renal dysfunction. The most common time frame was between postoperative days 2 and 9. The surgeries with the highest risk were emergency surgery, vascular surgery, including carotid endarterectomy, and thoracic endovascular aortic repair, and brain surgery. The majority of perioperative stroke events in non-cardiac and non-neurological surgery are due to ischemia, which may be from hypotension and low flow states, previously unknown large artery stenosis, anemia-associated tissue hypoxia, thrombus, fat, or foreign material embolism, enhanced coagulability, or thrombosis in the setting of systemic inflammation and or recent discontinuation of antithrombotic medications. There is an opportunity for enhanced education when it comes to diagnosis and management of perioperative stroke for patients and clinicians. In addition, risk factors may be under-recognized during the preoperative period. There is a study of Canadian anesthesiologists that identified knowledge gaps in anesthesia professionals related to perioperative stroke. Results of this web-based survey study revealed that less than half of the respondents correctly identified the overall incidence of stroke in the perioperative time period, and only a quarter knew that thrombosis was the most common etiology. In addition, 64% of respondents believe that the overall risk of dying from perioperative stroke is rare, but the actual stroke-associated mortality rate is quite high at 25 to 87%. For most of the respondents, there was a disconnect between knowledge about perioperative stroke and confidence providing care to patients at high risk for stroke. We hope that you will check out the whole study, and I will include the citation in the show notes as well. One question that comes up in preoperative anesthesia clinics around the world is related to the timing of elective surgery for patients who have had a prior stroke. We know that patients with a history of stroke have a higher risk for complications, including perioperative stroke, but this risk decreases over time. Let's look into the literature. There is a 2011 retrospective study evaluating the Danish National Health Database that found the greatest risk for ischemic stroke and cardiovascular death was within the first 3 months following the initial event for patients undergoing elective surgery. This risk appeared to level off at about 9 months. The 2021 American Stroke Association, American Heart Association guidelines incorporated this data and recommended delaying elective surgery following stroke for 9 months with consideration for surgery after 6 months if the benefit outweighed the risk of waiting. Fast forward to the 2022 study by Glantz and colleagues published in JAMA Surgery. Association of time elapsed since ischemic stroke with risk of recurrent stroke in older patients undergoing elective non-neurological non-cardiac surgery. This is a cohort study of 5.8 million patients that revealed that the risk of stroke and death leveled off after only 90 days between a previous stroke and elective surgery. These results led to new guidelines. In 2024, a joint guideline by the AHA, ASA, and other international societies for perioperative cardiovascular management of patients undergoing non-cardiac surgery was published. The updated guidelines recommended that patients wait at least 3 months after stroke before undergoing non-cardiac surgery to help decrease the risk of recurrent stroke and/or major adverse cardiovascular events. I just want to highlight this recommendation for all anesthesia professionals who may find themselves being asked how long to wait to schedule surgery for patients who have had a stroke. According to the latest guidelines, it is appropriate to wait at least 3 months after the stroke. You can help your entire department stay up to date with the most recent guidelines. Speaking of preoperative recommendations, we have more to talk about. Let's review the guidelines for the prevention of perioperative stroke published by the ASA and AHA in 2021 and the Society of Neuroscience and Anesthesiology in Critical Care, or SNAC, in 2020. Preoperative recommendations highlight a multidisciplinary approach to preoperative testing and optimization and appropriate medication management, especially when it comes to beta blockers and anticoagulation. Before we go through the recommendations that are listed in Table 1, I want to highlight some of the differences between these two published guidelines. The SNAC guidelines advise caution with the use of intraoperative metoprolol, since it has been associated with perioperative stroke, with considerations for using other beta blockers. The ASA/AHA guidelines recommend continuing beta blockers. Other key differences come from the ASA/AHA guidelines pertaining to the increased risk for perioperative stroke in patients with a patent foramen ovale, the use of web-based American College of Surgeons surgical risk calculator, and carotid artery revascularization for patients with symptomatic carotid artery stenosis greater than 70% before elective surgery. The guidelines are also different in the management of patients taking vitamin K antagonists, but both agree that for patients at high risk for thromboembolic complications, bridging with either therapeutic low molecular weight heparin or intravenous heparin is appropriate. There is further agreement that aspirin, warfarin, and direct oral anticoagulants should be held before elective surgery, depending on the bleeding risk, and restarted shortly after surgery with heparin bridging only required for high thromboembolic risk cases. Make sure to continue aspirin for patients who have undergone percutaneous coronary interventions. Statin therapy may not reduce the risk of stroke, but may improve other outcomes. You may need to have a discussion with surgeons, anesthesia professionals, neurologists, and other medical professionals to develop a comprehensive preoperative plan for anticoagulation management. It's time to go through Table 1 in the article for a summary of the preoperative considerations. This is an excellent resource for anyone in a preoperative anesthesia clinic. First up, the preoperative evaluation. Here are the important considerations. All patients should be assessed for their perioperative stroke risk, specifically increased age, renal disease, history of transient ischemic attack or stroke, and patent foramen ovale. Patients at higher risk of perioperative stroke should be discussed by a multidisciplinary team. Consider using the web-based ACS-SRC to assess risk. Delay non-cardiac surgery for greater than 3 months following cerebrovascular event. Next up, there is a recommendation for preoperative optimization. Perform carotid artery revascularization in patients with symptomatic carotid artery stenosis of greater than 70% before elective surgery. Finally, we get to medication management, which includes the following considerations. For beta blockers, continue prescribed beta blockers, but do not start beta blocker therapy. For aspirin, do not routinely continue aspirin solely for stroke risk reduction. Consider continuing aspirin in patients at high risk for a major adverse cardiac event, such as patients on aspirin for secondary prevention, if the benefits outweigh the risk of bleeding. Aspirin should be continued if there is a history of percutaneous coronary intervention. For warfarin, hold for 5 to 6 days before surgery. Restart 12 to 24 hours after surgery. Consider heparin or low molecular weight heparin bridging for high thromboembolic risk only. For intermediate risk, bridging is at the clinician's discretion, and bridging is not recommended for low risk. For direct oral anticoagulants, high bleeding risk surgeries hold 3 days prior and restart 2 to 3 days after surgery. For low bleeding risk surgeries, hold 2 days prior and restart 24 hours after surgery. Bridging is based on clinical judgment regardless of the bleeding risk. Timing of resuming anticoagulants should be discussed by the multidisciplinary team. Now it's time to head into the operating theater to talk about intraoperative considerations to minimize the risk for stroke. Check out Table 2 in the article to follow along. Here are the important considerations. Maintain mean arterial pressures greater than 70 millimeters of mercury, especially in patients with moderate to high perioperative stroke risk. Pay careful attention to blood pressure gradients between the brain and wherever the blood pressure is being measured in order to avoid hypotension. Transfuse to a hemoglobin greater than 8 grams per deciliter in patients with recent stroke or cerebrovascular disease and maintain the hemoglobin between 8 to 9 grams per deciliter if there is a history of recent stroke, ongoing bleeding, or hemodynamic instability in the presence of known cerebrovascular insufficiency due to occlusion or stenosis. Consider transfusion to a hemoglobin of greater than 9 if patients are taking beta blockers to help decrease the risk for perioperative stroke. There are no specific recommendations for or against the use of regional versus general anesthesia, and no recommendations against the use of nitrous oxide or volatile anesthetics versus total intravenous anesthesia. There does appear to be a benefit of regional anesthesia for joint replacement surgery, likely due to the differences in blood loss and the risk for thromboembolism. Maintain normocarbia, and maintain a serum blood glucose between 130 and 180 milligrams per deciliter. We have made it out of the operating room. It's time for the postoperative recommendations. Let's turn our attention to Table 3. Here are the recommendations. If concerned for perioperative stroke, obtain emergent brain imaging. If there is a high suspicion for perioperative stroke on brain imaging, a multidisciplinary group discussion is warranted to recommend either intravenous thrombolytics and/or the use of mechanical thrombectomy. If the patient is given recombinant tissue plasminogen activator, maintain systolic blood pressure less than 180 and diastolic blood pressure less than 105. Additional testing should include an EKG, troponins, and cardiac telemetry for at least the first 24 hours. Avoid hypotension. Aim for MAP targets greater than 70 millimeters of mercury in patients at moderate to high risk of stroke. Initiate aspirin therapy in the first 24 to 48 hours after ischemic stroke onset, but this can be delayed until after 24 hours in patients who have received TPA. Maintain serum blood glucose between 140 and 180 milligrams per deciliter. Remember, this is a time when anesthesia professionals can have a big impact on keeping patients safe by providing appropriate hemodynamic monitoring and management, ventilator support, and safe patient transport to imaging, procedural rooms, and hospital floors and intensive care units. Anesthesia professionals need to be aware of the risks for perioperative stroke and be knowledgeable about recommendations and guidelines to help decrease the risk and recognize this complication when it occurs. Here are the big takeaways. Delay elective surgery for at least 3 months after stroke. Consider a multidisciplinary approach to perioperative optimization and planning for high-risk patients. For patients with symptoms concerning for perioperative stroke, emergent evaluation is critical with early engagement of a multidisciplinary team. Before we wrap up for today, we are going to hear from Nadler again. I also asked him what he hopes to see going forward. Let's take a listen now.
I can imagine several developments that would significantly improve our perioperative outcomes. Enhanced risk stratification tools, possibly incorporating artificial intelligence and machine learning or individual patient multiomics, will improve our ability to identify high-risk patients. Better bleeding risk profiles will let us develop more personalized anticoagulation management protocols. In the OR, we might see personalized blood pressure targets based on individual real-time cerebral monitoring technologies. And I don't know if we'll ever find the holy grail, a neuroprotective drug that can prevent damage in the setting of hypoperfusion, but research into the mechanisms of hibernation and ischemia reperfusion injury might allow us to precondition our at-risk patients or post-condition our patients who do end up having a stroke.
Thank you so much to Nadler for contributing to the show today. We are looking forward to the future with more tools to improve perioperative outcomes and help prevent perioperative stroke going forward. If you have any questions or comments from today's show, please email us at podcast@apsf.org. Please keep in mind that the information in this show is provided for informational purposes only and does not constitute medical or legal advice. We hope that you will visit apsf.org for detailed information and check out the show notes for links to all the topics we discussed today. Thank you for tuning in, and if you found this episode valuable, please share it with your colleagues, friends, or anyone interested in improving anesthesia patient care and safety. Your support helps us reach more listeners and spread awareness about the importance of safety in anesthesia. We're excited to share that the podcast is available on Spotify and YouTube, so it's easier than ever to listen and share. If you're on Spotify, make sure you click the bell icon to subscribe so that you don't miss an episode. Until next time, stay vigilant so that no one shall be harmed by anesthesia care.